What is the topic that was taught in the last class? Elderly, yeah. Okay, elderly. So health problems are elderly. So the problem is that we had so many health problems of the elderly. Just to recapitulate, what are the health problems of the elderly we talked about? Aging process. Mention some few problems. Huh? Aging process, what are some of the problems, health problems? From your last class, what do you learn, remember? Or what? Hearing impairment, vision impairment, locomotor impairment. Okay, then all these are there. Then you have hearing, vision impairment. Then your dementia, memory loss, all these things are there. Parkinson, etc. So the problem is that we have such a big issue, but still there was no proper national program, no way to assess it. How many people are elderly population? What are the problems? We don't have any idea. Okay. So this is the population of India. 2011 it was 10.38 crores. Now we are having census again. Personally, elderly is 8.6, and 2050 it's expected that it will be 20.6. Means every fifth person will be a geriatric person. Okay. So elderly population grows much faster than the general population. So again, this is the problems of many of them have disability. They cannot walk, they cannot see, they cannot hear. They have difficulty in problems like this, and they have mental health issues. They have multimorbidities, hypertension, chronic heart disease, stroke. All these are, as the age grows, these things become more. Okay. And the self-reported prevalence of diabetes. Self-reported means the person is himself reporting that he's got diabetes is about 1%, but there are much more there. Asthma, bronchitis, COPD is all high, and elderly people have self-reported eye or vision-related conditions. So these are all the burden of Now, how to start a national program like this? You must have some baseline data. How much, what is the people who are elderly, what are the problems, how to solve the problems, where to solve it. Okay, it's not easy. So with this, it was organized, started very recently, 2011, National Program for Healthcare of the Elderly, and it is an articulation of as per the UN Convention. And this is the aim is to provide dedicated health care to the elderly persons, so it's senior citizens. Okay. So this is the aim of the healthcare of the elderly. Now remember, it's a program which is started very recently. 2011 means 15 years. It is still in its infancy. Infancy means it has yet to take off in its full form for various reasons. So the objective is to provide accessible, affordable. What is the difference between accessible and affordable? What is accessible? What is accessible meaning?
So which is available?
Accessible, which is available.
No,
no. What is different? What is accessible?
Which is available easily.
No, okay, easily available. Yeah, okay, easily available. That is accessible. Yeah. Affordable is what is affordable? Which is cheap. Okay, and high quality. So normally, the thing is when it says as you said, affordable is cheap. People think, oh, quality is not good, but you need to give high quality care also, and long term, comprehensive and dedicated services. Okay, so this is to create a new architecture and to promote the concept of active and healthy aging, and convergence with other health programs like National Health Program, Ayush, etc. Okay, so basically you have three components. First is National Health Mission component, second is tertiary component, and third is research. Now in the National Health Mission component, you have primary and secondary delivery care through district hospital, CHCs, PHCs, and sub-center or wellness center. Tertiary component is provided through regional geriatric centers, RGC, and national centers of aging. It's also called as Rashtriya Varisht Jan Swasthya Yojana in 2016-17. So these are actually very recent. Okay. They might certainly ask you, and then the research is a longitudinal aging study in India called LASI project. Okay, these are the main things, thrust of the program for this thing. So primary, basically primary and secondary services is provided through district hospital, CHC, and the primary health center, and also sub-centers. Tertiary care, specialized care is supplied, given through specialized centers, which is national aging centers and regional geriatric centers. Okay. So what does the patient get at what levels? What does he get at the PHC level? What does he get at the CHC level? What does he get at the district or taluk hospital level? We'll look into that. So first is community-based health, which includes domiciliary health visits by trained health nurse. Now remember, domiciliary visits by trained health nurse. This is very important. What is the meaning of domiciliary? What is the meaning of domiciliary? Domiciliary manatake. What is the meaning of domiciliary? What is the meaning of domiciliary? Not hometown, home visits. Okay. So basically, when we were studying, before I was studying MBBS, we used to have doctors used to come for home visits. Okay. The doctor apni body ka ashan, they'll come. Today nobody comes. Now in this situation, that is called domiciliary care. Where that was a doctor's visit at home. Domiciliary care means a bedridden patient. What will you do? বয়স্ক লোক শুয়ে পড়ে আছে, কি করবে? Doctor কাছে যেতে পারছে না. Somebody has to come to the house. That is done by the trained nurses, okay, by trained health workers, and provisions including machinery, equipment training, additional human resources, then dedicated facilities at district hospital with at least 10 beds for geriatric patients. That is the aim. Hoini, I can believe it's the aim. Additional human resources, machinery, equipment, consumables and drugs, training and IEC, strengthening of regional centers and to provide tertiary level medical facilities for elderly, introducing PG courses in geriatric medicine. Now, when we were studying, we never knew about a term called geriatrics. Geriatrics came much later. Today they have geriatric courses. You have MD geriatrics in a few places. Before that, there was diploma in geriatrics from places like Vellore, Jipmer, I think AIMS also. Now you have MD geriatrics. Just like MD pediatrics, you have MD geriatrics. So that's a new subject, but it's catching on. And in-service training of health personnel, in IEC using mass media, folk media, and continuous monitoring and independent evaluation. Okay, so expected outcomes is establishment of geriatric centers in Department of Geriatric Medicine. Now, geriatric medicine is different from other sources, obviously, other medicines, because the age group is different, their problems are different, and various things. So, establishment of geriatric medicine regional geriatric centers called RGC, conducting training of health personnel, and also post-graduation in geriatric medicine, 2 seats in each of the regional geriatric centers, district geriatric unit in all district hospitals, and OPD rehabilitation units including visits at CHC and health and wellness center, provided with equipment for outreach service for elderly. So training of people also. Now, for example, in some states, like they've been having what is called palliative care. Now, what is palliative care? Any idea what is the meaning of the word palliative care? What is palliative care? What is palliative? The meaning of palliative? Take a try. What is the meaning of the word palliative? To comfort the patient. Okay, comfort the when? You're right. Okay, to comfort the patient when there is no definite treatment. Basically, when he's having a terminal illness, when he's got, say, cancer and it is spread, then nothing more can be done. So that is the time when you have palliative care. So palliative care is a big movement in many parts, in some places, like for example, Kerala. Kerala started about 20-25 years ago, and they still have people who go to various houses where they need palliative care. You have nurses, you have volunteers, social workers, doctors, etc., who do palliative work. So that is actually, you can say, a precursor of geriatric work. But palliative care deals basically with terminal patients. Okay, somebody who's just had a stroke, he may live for 20 years. The palliative person will not go there. So we need geriatrics unit for that. Okay. So again, this is the expected outcome. We have at the sub-center level, we have home-based care, okay, the domiciliary care. When the public health nurse comes to the house. Second one is geriatric care at the second level is PHC, where you have geriatric clinic on fixed days. Now, can you mention a few issues regarding geriatric clinics? Geriatric clinics on fixed days. Tell me some of the issues regarding geriatric clinic is something very interesting. Very interesting means it has a lot of question marks. Suppose you get into MD geriatrics, you've finished and you're starting a clinic. What are the things that you will do? What would you like to do? You've got a place, you started you finished your MD geriatrics, you wanted to make it an ideal geriatric clinic. What will you do? Ideal geriatric clinic, what will you do? Just give some suggestions. Use your logic. What are the possible problems in a geriatric clinic? You have, suppose this is a clinic. People are waiting, all geriatric patients, people are waiting for the doctor. What are the problems that will be there? What should be facilitated? Use your brains a bit. Doctor is very busy, he comes very late. People are waiting for him. The geriatric patients are waiting for him. What is the issue? Doctor is busy, people are waiting, all these people are waiting for doctor. All of you are patients, geriatric patients waiting for doctor. What are the issues? Well, what are the issues? What are the issues? Doctor Babu, kokon asbe, kab aayega doctor? So what is the problem? Social problem with geriatric patients. Use your brains a bit. No problems. Huh? No problems at all. No problems at all. Huh? Bolo, what's the problem? Oh, huh? Huh? Ha, দাঁড়িয়ে থাকতে হবে, very good. দাঁড়িয়ে থাকতে হবে, there's one. কেন দাঁড়িয়ে থাকতে হবে না? দাঁড়িয়ে থাকতে হবে, ঠিক আছে, বসে আছে এখন, সবাই বসে আছে. What else? Any other problem? You are right. And what else? Now come on, you come to the point. Go a bit further. He's sitting down, দাঁড়িয়ে থাকতে হচ্ছে, উঠতে পারছে না, আর কি হতে পারে? আরো বলো, you're right, হ্যাঁ? কথা বলতে না পারতে পারে, his condition, ওটা ছাড়া আর কি? কথা বলতে না পারে, what else? He wants to go to a toilet, ওখানে পাশে টয়লেট, ওয়াশরুম অনেক দূরে. He wants to have some water, জলটা নিয়ে আসতে হবে বা বাইরে যেতে হবে. These are special problems for geriatric patients, okay? So geriatric patient clinics should be designed in such a way that the people get facilities. There should be a washroom, dedicated washroom. There should be also facility for water and whatever else, okay? So I have to just imagine this 80-year-old person, diabetic patient, he's waiting in the outdoor for a doctor. জল নেই, কিছু নেই, ডক্টর কখন আসবে, যেতে পারছে না. He can't go to a toilet, he can't go here either, because his number will come. It's difficult. It's really difficult. So they always ask, our number is, it's not easy. So that is the first thing. Then second thing is the construction of the geriatric clinic itself. It should be constructed in such a way that it's user friendly. There should be handrails. The seats should be comfortable for everybody. It should not be such a place that when the person sits, বসতে পারছে না, বসার জায়গা আছে কিন্তু বসতে পারছে না because it's so bad. So it has to be structured in a proper way also. So these are the two main things in a geriatric thing. That is the infrastructure and the waiting time and the associated facilities. Okay. Then district hospital again, you have a daily geriatric clinic. In the district hospital, you have daily geriatric clinic. In PHC, you have on fixed days. District hospital daily, and district hospital also has in this primary health center or community health center, you have only geriatric clinic. But in the district hospital, you have a geriatric ward of up to 10 beds. And tertiary level, regional geriatric center, 30 beds for geriatric patients. These are the projections, okay. Unfortunately, we have not done that, reached that way. So at the subcenter level, what is the package? At the subcenter level, education related to healthy aging. Okay. Domiciliary visits for home-based, homebound or bedridden patients. Provide training to the family members in looking after the elderly caring patients. Now, this is something which all of us will face at some point in life. Looking after elderly, disabled elderly persons. बोलते बारे की प्रॉब्लम होते बारे looking after disabled elderly persons in your own house, for example. What are the common problems? What could be the problems? Well, huh? You say you have your grandfather or somebody very sick, you can't, he's immobile. What are the problems that you face? A stroke hoise, শুয়ে পড়ে আছে, 80 years. What are the problems that can be? Bolo? Yes? Huh? Washroom জন্য help করে. Okay. First is he's bedridden. He cannot go to the washroom on his own. তখন কি করবে? What is the next thing? He cannot go to the washroom on his own. So there are what are the options? বলো. What are the options? Washroom যেতে পারছে না, কি করবে? মাথা নাড়াচ্ছে বলো. Diaper is one. Okay. Then diaper is one. The second is use a urinary catheter. Okay. And that is to be changed. Okay. These are the two main things. And also you can use a condom catheter. These are the common things. Same thing for stool. Again diapers. Okay. So these are then not only that. You said about washroom and this. What else? Aki position shule ki hoy. Bed sore. So how to avoid the bed sore? How to avoid the bed sore or how to? Huh? What did you say? Ki korte hoy? Huh? No, cleaning, forget, what else? Massaging is one thing, then what else? You need air bed or the water bed in which the patient automatically moves from side to side. Okay? So that is one. So these are the problems which the family members should know. Family members একটা লোক শুয়ে আছে ওখানে 85-year-old বাড়ি লোককে জানতে হবে. Now the question is again, the question is বাড়ি লোক কি জানতে হবে? বাড়ি লোক catheter পড়াতে জানে না, but they know urine how to empty the urine sac, how much urine is come, that they can measure. Okay, because a doctor will ask or who was the healthcare কত urine output হয়েছে 500 ml 400 ml, that should be measured. The person in the house who's, if he or she is not a medical person, will not be able to introduce a catheter or things like maybe diaper, yes, but otherwise it cannot be. Similarly for feeding, Ryle's tube feeding for a lot of people. The Ryle's tube feeding again should be done by an expert, somebody who's trained in the medical thing. So সেটা বাড়ি সবাই করতে হয়. But these are the basic things which are there. Apart from that, that particular person's room should be kept hygienically. ঠিক আছে? So a lot of places it's not kept hygiene. They say বাড়ির লোক ওখানে শুয়ে আছে, দাদুর শরীর খারাপ, leave like that. But rest of the family sitting and watching TV or cricket or whatever, that should not be the case. His room should also be kept clean. That is the rule of the family health care providers. Arrange for suitable calipers and supportive devices for the patient from the PHC to make them ambulatory. So some of the things which are there which the person can actually use, they get in the PHC like calipers. You also get this walker sometimes, and linkage with other support groups and daycare centers. Okay. Now regarding this LASI is that long-acting study on this. They are collecting data on disease burden, healthcare and healthcare financing, family social network, and social welfare problems for elderly. And this report was released in January 2021. Okay. So this was a study, longitudinal aging study in India. It covered all states, and this is a sample size of 72,000 and 31,000 above the age of 60 years. So this is the sample size. I mean, this is a study on aging. Now these are some equipments which are as per NPHC. Some equipments will be kept in health and wellness center and NPHC's. Shoulder wheel. Do you know what a shoulder wheel is? Any idea what a shoulder wheel is? How many of you go to the gym? Gym mein kyun gache? Anybody's gone to the gym? Nobody. Nobody's been to the gym. I can see somebody is saying yes. Nobody's been to the gym. Gym jao nahi. So you have something like a steering wheel, okay? Gadi steering wheel. That gives, if you see you can see the net, it's called a shoulder wheel. That moving that gives you your muscles improve, okay? So your people who are old, they can try their hand on this shoulder. That's called a shoulder wheel. I didn't have the photo. I couldn't put the photo. Second one is wall ladder finger extension. You have, that's again something which you find in the gym. You have literally it's a sort of climbing tool, okay? So you move your fingers on each of the steps, and that's called a wall ladder finger exercise. Then you have finger exerciser web. Basically, you put your fingers to rubber band and you keep exercising them. That is, these are all the physiotherapy things which are there and are available at the primary health center level. Then free exercise weight cuff, 0.5 kg, 1 kg, 1.5, shoulder pulley, walking aid, adjustable walker, reciprocal walker, exercise couch, pillow, etc. And that is, the health and wellness center should also have floor patterns, okay? Floor patterns should be alternate patterns, different color tiles. That helps in teaching the gait pattern, okay? So if you have the same, what happens is you have the same color, there's a chance of falling. But if you have alternate colors, which contrasting colors, he looks at both the thing and there's less chance of falling. Wheelchair, then charts for teaching basic exercise, chart for teaching basic positioning, and the patient suffering from hemi-neglect, and spirometer. Spirometer is for the lung function test, okay? So at the community level, you should have, at the CHC level, you should have a spirometer. Basically, the person can know how much function of his lung is there if the spirometer is there. Have you seen a spirometer? Dekhe cho? Spirometer dekhe cho? Physiology dekhe, very good. Then primary health center, this is at the sub-center level. Primary health center there should be a weekly clinic run by a trained medical officer, okay? And maintain record of the elderly using as expected the format during the first visit. Now, getting the record of the elderly is very important because particularly the past history, okay? So many often the patient may not say straight. The patient may say, "Amar aage ekbar hospital bhorti hoyechilo, ei hoyechilo, sei hoyechilo." But you must have the document properly. Then you get the past history. Then conducting a routine health checkup, provision of medicines and proper advice on chronic ailments, and public awareness on promotional, preventive and rehabilitative aspects of geriatrics during health and village day, sanitation day camps, and referral for disease needing further investigation. So primary health center, you cannot do everything. If there's something which is major, you have to refer it to a community health center or a tertiary center. This is for PHC, you have slightly more things. What was there in the previous one only is there. Apart from that, you have this lower and upper extremity cycle or basic ergometer. Have you seen the ergometer? In physiology, have you seen the ergometer? Dekhe jo? In our time, there used to be an ergometer. Basically, you cycle on it, you know how many calories you're spending. Okay. That's called, I think it's still there in the physiology. They can maybe there. So, comprehensive geriatric assessment. First is screening for geriatric giants. Then you assess the socioeconomic status. You assess the comorbidities assessment, functional status, medication optimization, and nutritional assessment. And so the whole thing is there. Not just medicines. You need the comorbidity assessment, socioeconomic status, medication, functional status. So now these are some things which are required in the higher centers, in the geriatric centers. For example, Snellen chart. What is Snellen chart? Dekhe cho? You know what is Snellen chart? Yes or no? What is Snellen chart for? What is Snellen chart? Okay, visual, okay. So that is for vision, okay. Then again, for hearing, you have a handheld audioscope, For nutrition, you have a mini nutritional assessment scale to assess the nutrition. Similarly, you have for mental health, you have a mini mental assessment scale. Then you have a geriatric depression scale, an index of independence and home safety checklist. And you must also have BP apparatus, thermometer, glucometer, HbA1c kit, hemoglobinometer, pulse oximeter, spirometer, and handheld dynamometer. So these are all things should be available with the primary health PHC team. Okay, these are all things which are required. So once again, at the community level, the ASHA worker is the first person. She just goes through the checklist. If there is any problem, she refers to the multipurpose worker. That multipurpose worker, he does the history taking, basic details. Then it goes to the community health officer, screening for geriatric syndromes, functional assessment. Then the medical officer will screen if there is more than three red flag signs. What are the red flag signs? If the age is over 75, living alone, need help with activity, history of fall, delirium, incontinence, more than 2 admissions per year, and failure to thrive. So if any of these things are there, our repeat coaching, the MO will screen if the age is more than 75 years, or if the person is living alone, or if he needs help with activity of daily living. He needs somebody to help him to bathe, etc. Or if he's got a history of fall or delirium, or incontinence, or more than 2 admissions per year, failure to thrive. Then the medical officer comes in and then he screens for all this. Screening for memory loss, screening for cognitive impairment, screening for depression, fall risk evaluation, and comprehensive geriatric assessment report will be prepared. So this cannot be done by an ordinary medical officer. Please remember, this needs somebody who's either MD pediatrics or has undergone some training in pediatrics, in geriatrics. So ordinary person will not be possible for him to fill in. But this is the thing. So the important thing is, if more than 3 red flag signs, more than 75 years living alone, need help for daily activity, history of fall, delirium, incontinence, more than 2 admissions per year, and failure to thrive. Then the medical officer does a comprehensive geriatric assessment. So then this question is home safety environment. Ask the senior citizen if he's got problem with lighting or with stairs inside or outside the house. Now healthcare worker has to assess the following. Is the bathroom slippery and wet? Is there any provision for a caregiver at home? So nowadays it's a nuclear family, husband, wife, one child gets a job, gets married, goes away. Only husband and wife are there. They are both senior citizens now. One of them falls sick. So is there provision for anybody, for a caregiver at home? Yes, no, not applicable. Is there any ramp for elderly using walking aids or wheelchairs? Now this is another thing for geriatric clinics. You need a ramp for the patient to come. Or wheelchair, okay. And are there any handrails and staircase in bathrooms? Yes, no, not applicable. So here the multipurpose worker is responsible for this, and what happens is prevention of fall risk at home. That is the net outcome, okay. Then you have again, this is another assessment of independence. What are the activities which can be done with or without help, like bathing, dressing, toileting, transferring, continence feeding. So this again they are broken up into 2 things. Whether he can bathe completely or he needs help at one part. He may be able to bathe in some part of the body, but not everywhere. Similarly, dressing, help with dressing. Some people may not need help in dressing. Like for ladies, they may find it difficult to dress with saris, but they may find it easier with, say, chudar or something like that. So that is one thing. Similarly, toileting, whether he goes to toilet on his own or needs help transferring to toilet, cleaning self, transferring, moves in and out of bed unassisted, or you need the patient somebody to move him out of bed. Similarly, continence, that is your urinary output, feeding, whether he needs partial help or complete help for feeding. So these are all the things. Again, the community health officer is responsible. Bathing, independence, dependence, dressing, toileting, transferring, continence, feeding. Total score. The score is 6. He is independent. If it is 0, it is very much dependent. Okay. This is the assessment of independence. So as the problems increase, the dependence becomes 0. Patient is very dependent. So you have this acute illness, comprehensive geriatric assessment, acute illness, comorbidity, geriatric giant syndrome, other age-related problems, social problems, suggested prescription modification, and advice and care. So this we already talked about. What is this one? Oh, yeah. So depression. Now this is important. Geriatric depression. Now our depression is different from their depression. Our depression is what? You have failed in your exam, that is depression. You've done badly in your exam, that is depression. But their depression is for a longer time due to various reasons. So you have a big set of questions. You don't need to, I'm just going through some of the questions. You don't need to remember it. But the questions are like this. Are you basically satisfied with your life? Yes or no? Have you dropped many of your activities? Do you feel that your life is empty? Do you often get bored? Are you in good spirits most of the time? Are you afraid that something is going to happen to you? Do you feel happy most of the time? Yes or no? Do you often feel helpless? Do you prefer to stay at home rather than going out and doing things? Do you feel that you have more problems with memory than most? Do you think it is wonderful to be alive now? Do you feel it is worthless the way you are now? Do you feel full of energy? Do you feel that your situation is hopeless? Do you think that most people are better off than you are? So this is the geriatric depression scale. Here again, total question 15. If the answer to that is 5 or more, it suggests depression. So here, we talked about the subcenter level and the PHC level. So what does CHC do? CHC is the first referral unit for the elderly, for PHCs and below. Geriatric clinic for elderly people twice a week. Rehabilitation unit. Domiciliary visits for bedridden elderly and counseling of family members on the home-based care. Referral to higher centers, difficult cases. So again, at the CHC, you need more equipment than the primary health center. Among the equipment you need is glucometer, nebulizer, pulse oximeter, glucometer, nebulizer. These are some things which you require. And defibrillator. What is a defibrillator? What is a defibrillator? What is a defibrillator? What is a defibrillator? Bolo? Have you heard what is it? Do you know what is a defibrillator? What is it? Unconscious patient? No, what is a defibrillator? If you study physiology, the patient does not have to be unconscious. No, the patient does not have to be unconscious. Bolo, what is a defibrillator? Electric shock. Okay, when is it given? Cardiac arrest. Patient does not have to be unconscious with it. So that is also there. Then you have shortwave diathermia, cervical traction, walking sticks, calipers, shoulder wheel, and pulley walk. These are equipment which are available in the community health center, CHC. So once again, at the CHC level, you have nebulizer, glucometer, ECG machine, pulse oximeter, and defibrillator. Okay. District level, what do you have? The geriatric clinic for regular dedicated OPD services and facilities for lab diagnosis, provision of medicines for geriatric medicine and medical health problems, 10-bedded geriatric ward. Okay. We also have a 10-bedded geriatric ward. What's going on there? Mr. Person in the cap. Any problems? It's the class is getting over shortly, don't worry. Okay. So, here. So, now here is the question. Geriatric medicine is a subject by itself, but what are the other specialties that need to come? You need existing specialties like general medicine, orthopedics, opthal, ENT will provide services needed by elderly patients, provide service for the elderly patients, for CHCs, conducting camps for geriatric patients, and referral services for severe cases to tertiary level hospitals. Okay, so you have your existing specialties, they are also adding to it, and these are the other services which are required. Regional geriatric center is most specialized. You have 30-bedded ward, dedicated beds for surgery, ortho, psychiatry, urology, ophthalmology and neurology, and lab investigation facilities also there. Tertiary care, healthcare to the cases referred from medical colleges. Okay. So the regional geriatric cases centers are not there everywhere. It's a very specialized geriatric case. Then you have National Center for Aging is also there, which is higher than the geriatric centers. Okay. You have the National Center for Aging is also there. So OPD care in various disciplines. You have memory clinic, more specialized thing, memory clinic, fall and syncope clinic, frail elderly clinic, and AIDS and appliance clinic, implants, etc. And there is also daycare center for investigation, rehabilitation, respite care, dementia care, incontinence care. And in IP care, for this, in the aging clinic, you have intensive care, acute rehabilitation, diagnostic and therapeutic services, long-term rehabilitation, and HRD in all subspecialties. Okay. So we are still developing evidence-based protocol for them. Special focus on those who are over 75 years. So why over 75 years? Because they have more problems. Till 75 years, it's not that bad. After 75, it's you reached the end of your life. I mean, the active life. Okay. So now let's come to the progress. These are all fancy things which were said in 2011, but we have not really gone full-fledged in it because financial resources, planning, training, etc. So the idea was that this was the thing in the 12th plan period. We had 100 districts were sanctioned to provide dedicated geriatric care, and then later on it became 421 districts. Then it became 713 districts. Okay, in 2019-20, it became 713 districts. Yet it does not cover the entire country. So tertiary level, we have done 19 geriatric centers in selected medical colleges. OPD is provided through 18 regional geriatric centers. 250 bedded geriatric center at PGH Chandigarh. Okay, 250 bedded. The only place which has got a high intensive thing is at PGH Chandigarh, and 2 national centers for aging at Chennai and at AIIMS, Madras Medical College Chennai and at AIIMS, as center of excellence for geriatric service. So these are high things which are being done. Tertiary levels of NPHC and regional geriatric centers. These are the south centers. For us, the nearest one is Calcutta Medical College, my alma mater, and you have other than that you have AIIMS, BHU, Mumbai, Grant Medical College, Mumbai, Gautam Medical College, Medical College Trivandrum, Madras Medical College, Sher-e Kashmir Medical College, KGM, King George in Lucknow, Rajendra Prasad, Himachal Pradesh, Jodhpur, SN College, RIMS, Ranchi, Bangalore Medical College, Nizams, BJ Medical College, Ahmedabad, SCB, Cuttack, Agartala, and Bhopal Gandhi Medical College, Patna Medical College, and Government Medical. So for us, the nearest is Kolkata Medical College. Okay. So this is the last thing in 2021. What all was done actually? As per the progress report, we had so many OPs in the regional geriatric centers, indoor admission with this, and lab tests were so much, and it's not gone fully as we expected, but still it's just going on because we have yet to reach a lot of the fund resources, the planning, and geriatrics is by and large lesser priority than other things. Okay. So this is the National Center for the Geriatric thing, NPHC. So what was the aim and so finally summing up, the aim of this NPHC was to result in a better, healthy elderly community with better physical and mental health independence. And this program has actually emphasized the need for better health and to identify the problems for the elderly community and to give them various services, geriatric services at various levels of healthcare. To provide the access to promotive, preventive, curative and emergency healthcare among elderly patients. Promotive, preventive, curative and emergency healthcare. So provide comprehensive care to train health professionals, including supportive care and rehabilitation, identify health problems in the elderly and provide appropriate health intervention in the community with strong referral backup, to provide referral services to the elderly patients through district hospitals, regional medical institutions. Now what happens in Western countries? Western countries, somebody is sick, what happens is in UK and USA, he's bedridden. So here if he's bedridden, first of all in UK you have everything comes under National Health Scheme, NHS. So to get in, you need time. Not like here you can get into a hospital anytime, mostly. So what happens there is a nurse comes to the house. So she comes on a routine. She comes once a week or twice a week and checks on everything. Does everything which a doctor does. Here, unfortunately, that is not happening. Nurse does everything, but quite a lot of things, but not everything. So the nurse is like a doctor in the UK. She comes every week to see the bedridden patients. And these are some of the programs which are there. National Policy for Older Patients, Old Age Social and Income Security, OSS, Indira Gandhi National Old Age Pension Scheme, and PACE, Program of All-Inclusive Care for Elderly. These are some of the other national programs. So National Policy for Older Patients is to strengthen their place in society. You give old age pensions, houses, shelters, welfare measures, health and nutrition, and financial support to NGOs. Now here, NGOs are the major thing. Government does not have that much money. NGOs are there who help, some NGOs. So what are the NGOs? Help Age Foundation is one thing. Age Well Foundation is another one. Age Care India is another one. Elder Home Society is another one. And Age Care Center for Retired Persons. So these are some of the NGOs that are actually working in the field of geriatrics. Okay. So I think that's my last slide. Yeah, it's my last slide. So basically you need to know what is the thing, so what are the levels of treatment at the primary health center, at the sub-center, primary health center, then the community health center and the tertiary centers, and what are the package of services that are given, and this is the structure. If you remember the structure, it's very easy. You have home-based care at the sub-center level, CHC, PSC, geriatric care on fixed days, district hospital, daily geriatric clinic with geriatric ward, 10 beds, tertiary level regional geriatric center with 30 beds. Okay, so I think that's all. Okay, so that's all for now. Thank you.